very much, Ronelle. A warm welcome to all of you, and thank you for coming. I'm just glad that we are obviously outside our own high season for respiratory illnesses, and I do hope that none amongst you has just returned from Wuhan with a respiratory tract infection and fever, because I mean these crowded settings are of course very conducive to the spread of respiratory infections. But luckily it's our summer, so it's not our main problem at the moment. It gives me great pleasure to introduce my colleagues who are also going to give presentations. Dr. Jantjie Taljaard, the head of Infectious Diseases, Adult Infectious Diseases, and he's the person that I always turn to with my own ID-related questions, so he's obviously the best person to ask. He's also in charge of the, can I say, the designated facility for the Western Cape to deal with any potential cases. And Dr Nokwazi Nkosi, she is a specialist virologist, consultant virologist in our division, and she will briefly touch upon the diagnostic testing that is being done. We've had a change of program, as happens with these very acute cases. No representative from the Provincial Department of Health was able to join us because they are frantically working on their preparedness schemes and SOPs and protocols. So they send their apologies. I've got a few slides from them, but we will keep that relatively short. And of course, I have to say that, beautiful as it is to be able to fill the venue like this, I wish any of my lectures were attended by so many students. You know, it is beautiful, but of course a very hot topic like this one is also a difficult one. So thank you to WHO for changing to a global alarm last night. You know, it's not what you want to do. You want to prepare your slides the day before, 2 days earlier. You don't want to keep adding up figures and numbers until the last moment, but that is what it is. And of course, we have to say that whatever we say reflects what we know and where we are today. And these things are unfolding rapidly, so you know, in a week's time, in 4 weeks' time, in 8 weeks' time, things may look a bit different. So let me give you a bit of an introduction, a background to this. It's a clumsy name, 2019 N for new or novel coronavirus, nCoV. I prefer the city name. Obviously the city itself doesn't prefer that name, Wuhan coronavirus. So what has happened? From starting in early December last year, there have been increasing numbers of pneumonia cases in Wuhan City, that is the Hubei province in China, very big city of, I believe, 11 million inhabitants. And they were unusual in that diagnostic testing did not reveal any of the usual culprits, any of those pathogens that you would expect. Remember, up in the northern hemisphere, it's now winter, so they are also in the midst of their influenza season. So that is also something which makes the whole situation much more difficult, because you have something new occurring on top and in addition to, you know, and we know from our own winter that, you know, there are times when just about everybody seems to be coughing and sick and not feeling well. That makes the whole thing a bit more complicated. But these were unusual cases, and there were a few dozen for which there was no obvious reason. And then in late December last year, so about 4 weeks later, the Chinese authorities informed WHO that there was an outbreak with a few dozen cases at that stage, and they informed WHO on the basis of the international health regulations, which want countries or require countries to report any health-related events that may have implications for other countries so they can prepare. And they also said that at the time that they had shut down a seafood and wildlife market that was linked to those early cases. Okay, and then those of us who've been around for a few years, or not to say decades, like myself, they of course think back, wildlife market, respiratory illness. Now I am mentally transported back to 2003 to SARS, and we talk about that a bit later. And a week later, in early January, it was announced that a new virus had been discovered, and that new virus was a member of the coronavirus family, which got this temporary name, but it was not any of those that had been known before. And that is in itself very remarkable, because the timeline is very fast. So we are now seeing everything in very fast motion here. Within 5 weeks of the first cases occurring, as far as we know, we don't know whether there might have been a trickle of earlier cases, but within 5 or 6 weeks, you know, you have the virus, you get a genetic sequence, and you can start making a test. The latest figures, and again, WHO's official figures are from yesterday. The unofficial reports are already higher. So currently, we have about 9,800 confirmed cases globally. The overwhelming majority of these cases is in China, and there's a hotspot in Hubei province, in which Wuhan City is located. And of those cases, 213 are known to have died. And if you do very crude calculations, that results in a case fatality rate of 2.2%. So basically 2.2% of those who are known to have been infected or to be infected with that virus have died so far. And outside of China, and that is the big thing, there are now 98 confirmed cases in 18 different countries. No fatalities so far, but that is, there is a spread outside of China, and I think this is also, obviously, of significance internationally. The problem is, and that is what I want to plead to everybody, you need to be very circumspect when looking at these figures. They keep changing, and then the question is, are these the official figures that are released by WHO, normally with a day or two delay, because they want to make sure they don't count double, and they have certain criteria. Media are often quicker, but then they are prone to double counting, so it's very difficult. And then you need to also distinguish what you're counting. A suspect case is somebody who fits the clinical and epidemiological definition, i.e. somebody with a febrile illness, respiratory tract infection, with a fever, with a link to Wuhan, and that may change in future, may now be a link to China, or somebody who had been there. And that's a suspect case by definition. But it remains a suspect case until such time that the patient has been tested with a specific test for the new coronavirus, and if found positive, it becomes a confirmed case. And if the lab test turns out negative, which it might well do and probably will do in the majority of cases, then the case is discounted. So don't conflate those different figures. It becomes very misleading and confusing. And then, of course, when you look at these figures, we all know that the more severely ill you feel, the more you are likely to seek medical attention. And only then would you be counted, and would you also get tested and then become a suspect, and later on possibly a confirmed case. So what about mild cases? They are likely underrepresented. How badly? How many of them we are missing, we don't know. But if you have a mild respiratory tract infection and a bit of a fever, but you're not really that unwell, you just stick it out. You stay in bed for a day, a hot toddy later, and you're fine again. And you will never be counted, you will never be known about. And then there's, of course, also the option of, which we don't know for sure, of asymptomatic cases, people who become infected, but who do not fall ill at all. So we don't know these things yet, and it's too early to say. So the latest nice maps that I pinched from various sources are 2 days late, but you see here really the hotspot here. This is Hubei province in the center of China with Wuhan City, and then you see pretty much all other provinces of China having had cases. So each dot is a case. But dramatically, and that is also what changed now the global assessment of the situation, is that we are seeing ongoing international spread of this illness. And these are the countries, and some of them are sort of also to others, but after 2 or so generations, this comes to an end. So luckily, so far, SARS and MERS have not taken the big step, to become a fully human pathogen. There are still zoonotic transmissions with subsequent spread amongst human beings, but they have not completely, in contrast to the many flu viruses, they have not taken that step to become fully adapted to living in the human population and just being a human virus. So there we are with this new virus down here, the red ones. We can be quite sure it's an animal species that's at the origin. I would imagine that the reservoir is probably a bat, but there would be something in between probably. And that is one of those, of the negative messages we're getting out of this. We've known this for almost 20 years, so why was it still allowed to carry on? Why do these markets still exist and act. And I like the expression of speed dating of viruses. When you bring so many different species together under bad conditions, so they're stressed, their immune systems are down, they shed more virus, and it all mixes very nicely. And any opportunity that such a virus may have to infect other species, it can exploit it, because you have a huge variety. So it's a perfect thing. We would not be allowed to do this in the lab, of course, because our ethics committee would not allow such risky procedures, but it happens in real life. It's very sad. The next unknown is, of course, will this outbreak be contained? Experts differ on that. The spread has been much faster than SARS. The virus is less virulent than SARS, so 2.2% of case fatality rate. We had much higher with SARS, and MERS is even higher than that. But paradoxically, what is good news, that more people become infected and don't become ill so badly, may also be more difficult for control, because then they're more difficult to detect and to diagnose. So it may work against controlling it. So there's pure speculation whether we may be witnessing actually the early stages of a new human pathogen. It's pure speculation, as I said, it's only from me, so please don't hold me by it, and I will change my mind as soon as new facts emerge, and I'm sure that will happen over the next year or so. But some arguments are that it is less virulent than the others, it is possibly infectious before onset of symptoms, or even from asymptomatic infected people. We don't know that for sure. It may be better at human-to-human transmission. We don't know. It's very easy to speculate. We don't know. Only time will tell. We can tell afterwards. And this has happened before. So in fact, some of these boring, common human coronaviruses are now known to have originated hundreds of years ago from different animals. So it's something that might just be happening again. If it happens again, it's most likely not the end of the world as we know it, because remember seasonal influenza, I know we all know it exists, and yet how many people do get vaccinated every year? I'm half up because I don't go every year, not reliably, but I try to, but sometimes I forget. And we know that every year, every flu season, 10,000 excess deaths occur in South Africa alone. So around the world, it's millions of people, and we have a vaccine. So, that is not a perfect vaccine, but it would lower the morbidity mortality of influenza, and yet we just sit through it. The problem with the new virus, even if it is not such a virulent one, if that is true, it would then be a virgin soil epidemic. And virgin soil means that nobody has had this before, because it's a new agent, so nobody would be immune. Anybody would be susceptible to it. And then, of course, it's a problem, because even 2.2%, if you calculate that up to the total population over a couple of years, is a horrendous number of people, and particularly the risk groups, the elderly and the chronically ill people, would be at substantial risk, whilst the first wave or waves of this new infection go through. And then finally, I'm coming to an end. Have we learned our lessons? I think partially yes. So I find it quite amazing how rapid progress was made with identifying the thing, developing lab tests and so on. I think there's been a lot more openness than during the initial months of SARS, but there are some accusations that Wuhan City tried to conceal the extent of the outbreak in December, and some people say, well, they should have said something then, because when it was fewer cases, we could have controlled it better. But on the other hand, one wonders why this very risky trade in wild animals is still tolerated or allowed, even though we know the risk, which of course applies to many things, not just infectious diseases. And then it's also...
I'm just going to give you an overview of the clinical aspects, and we're going to start with the symptoms and signs. We'll say something about the clinical case definitions. I'll just shortly show you one slide on the possible differential diagnosis of these cases. In other words, what else can it be? That's better. Yeah, okay. And then I'm going to say shortly something about the management, including infection control measures, and then the medical management of a potential case. And as Wolfgang has said, the world has an incomplete and rapidly changing understanding of the epidemic. So I think we need to take everything we say in that light. So in terms of symptoms and signs, this is a respiratory virus, as Wolfgang has said, and it causes fever, cough, and then sometimes difficulty in breathing. And those three main symptoms or signs, the incubation period is anything between 1 and 14 days, quite a wide range. In other words, from being infected to becoming symptomatic can be anything between 1 day after being exposed up to 2 weeks. And some people would say around the mean of 10 days, but with human-to-human transmission, it may be shorter. The evidence for those 3 main components of the clinical picture comes from the New England Journal, this was in Lancet Journal article where they described the first 99 cases from Wuhan City presenting with severe disease. And you can see there at the top, I don't know if you can read it, but it's fever, cough and shortness of breath, 80% and 30% with shortness of breath of patients presenting those symptoms. So that's where it comes from. They also added some additional information, clinical information on these cases. Now remember, these are the first cases presenting, probably majority of them, you can see their exposure to the food market, 50% of them actually had probably animal to human transmission. There was the blood results that showed a low lymphocyte count that they say can help you to consider the diagnosis. Personally, I think you would expect the lowest lymphocyte count with most viral infections, including influenza. Then majority were males, median age of 55 years. I don't know if that's so important because the majority of traders in that food market probably were males of that age. Many of them had chronic medical conditions, which may be something common in males of 55 years old, but it may have contributed to the relatively high mortality that we see there of 11%. And also, if you look at the chest X-ray findings of these patients, you can see 75% of them had bilateral pneumonia, which is a sign of very severe pneumonia. So this is a cohort of very severely ill patients, and does not necessarily tell you the whole story. For example, if you look at all the other symptoms, and again, if you can't read, those are muscle aches, confusion, headache, sore throat, runny nose, chest pain, diarrhea, nausea and vomiting. All of those were present. In other words, it's not all severe disease. And there's also some case studies presented of patients that only presented with low-grade fever and fatigue, and another patient described of only having back pain and general weakness and then being diagnosed with the condition. So my take on all of this early information is that we are sitting with a proper flu-like syndrome, and that's more or less it. We can break it down into different things, but at the end, for most of us, it would be a patient presenting with flu or flu-like presentation. And the WHO also tells us that the spectrum of this condition varies. You can have patients with uncomplicated illness. You can have patients with a mild pneumonia. In other words, they can still go home and stay at home because they just have a mild pneumonia. More severe pneumonias that's seen in the first cohort that's presented. And then obviously it can become very severe. You can have a situation where a patient presents very acutely with very severe lung disease that we call acute respiratory distress syndrome, and need to go to ICU and be ventilated, etc. And sepsis and septic shock can also be, in a minority of patients, sometimes a complication of the initial disease. So it's a wide spectrum of symptoms and signs that can present at the doorstep. We would usually think of a viral pneumonia if patients present with upper respiratory tract symptoms like a sore throat and a runny nose, and then come in with a pneumonia picture, and most likely influenza in our environment. And we have tested a couple of possible cases already at Tygerberg Hospital, and 2 of them have already come up as influenza. So, and just to say, there were no coronavirus infections, and there are none in the country at the moment. Bacterial pneumonia is kind of the normal pneumonia that you know about, that you present and you cough up yellow sputum and you've got a high fever. We would also consider that. And we would probably also give a patient antibiotics if they come in, and we don't yet know what the diagnosis is. We would give antibiotics early on to make sure that we cover for bacterial pneumonia. Also antibiotics for Legionella pneumonia, which is also a bacteria that is common, but it presents slightly different than a ordinary bacterial pneumonia. TB is also always something that we consider in South Africa. If somebody with lung disease, they don't usually present so acutely, but it is possible, especially in a more immunocompromised population, that people might present with a short history and then with severe tuberculosis. Pneumocystis pneumonia is a fungal type of pneumonia that presents mainly in people who are immunosuppressed. either having had an organ transplantation or being HIV positive. And that can present quite severely and look very much like acute viral pneumonia as well. And then other conditions that are not infectious are usually rare to present in this way, and by that time we would probably have already ask our learned pulmonology friends to come and have a look and tell us what's going on. I don't want you to read this. I know that the print is small, just the large blueprint. This is basically our Tygerberg Hospital protocol of what to do. And we start off with the case definition, obviously, which I'll go into more detail now. And then there would be a reporting of cases. If the case is reported, maybe comes from a peripheral hospital or from home, obviously the specific hospital needs to be phoned. If it's Tygerberg Hospital or Groote Schuur Hospital, it needs to be phoned. Infectious diseases specialist would give some advice on what to do, and then the patient will need to be transported by the emergency medical services. Usually they would, if it's Tygerberg, they would go to the ramp there, they would wait outside, wait for us to get everything ready inside, isolation room available, clear people, and when we are ready, the patient will be brought in with the necessary infection prevention control measures applied. And then I'm not going to say more about that process, but then I'll say a little bit more about the medical management as well, and then obviously ending up with public health response, which is a multidisciplinary response together with the provincial outbreak team, where all contacts are documented from the start and then followed up as well if it's a positive case. So the World Health Organization's case definition includes a severe pneumonia, as we've mentioned and as we've seen, any person with a severe lung illness, fever and cough, and you can't find another cause explaining this clinical presentation. And on top of that, they have traveled to Wuhan City, Hubei province, in the last 14 days, or they have an unusual or unexpected clinical cause, and that is a sudden deterioration. You don't know why, and it doesn't really matter if they've traveled or not, because this may be a case that doesn't fulfill your travel recommendations. And then very much the healthcare workers are at a high risk of developing the disease as well, and should always be seen as high risk and therefore also managed as such. There's a second possibility in terms of your case definition, and that includes a respiratory illness of any severity, because of you've seen now that it could be many different things. A person with a lung infection, any severity within the last 14 days, exposed to either close contact with a confirmed case of coronavirus, specifically while that person is symptomatic, because we think that the majority of high-risk transmission happens during the symptomatic phase. And then also, if there was access to a healthcare facility where patients like this was investigated and treated. I think case definitions are good to have as a public health intervention, but they must always be interpreted pending every patient's specific situation. All patients don't give you the same kind of history always. They may be very ill, not being able to give you a good history. We don't always know where these little towns are, where they tell us they come from, so it's also difficult to figure that out. And then also, a country has also their own specific kind of outbreak epidemiology that needs to be taken into consideration. How do people presenting in South Africa are going to present it? What kind of symptoms and signs will they have? And how common would human-to-human transmission be? We don't know that yet. So these case definitions can change. Wuhan City may change to China, maybe, we don't know. A lung infection might change to upper respiratory tract infection plus lower respiratory tract infection, and we'll see where that goes. Does it need to be a confirmed case, or can you only be exposed to a suspected case that's already in hospital being investigated? And does the patient need to be symptomatic? We don't know. It's still early days. They can also may have been asymptomatic and diagnosed. Okay, so in general, I would sum this up as if you are a healthcare practitioner or anybody that wants advice on a case and not sure, it would be a respiratory illness of any severity and travel history to China within the last 14 days. Please contact infectious diseases specialists at any place or clinical virologist and get advice whether this is a potential case and whether we should be looking more clearly at that. It's important also to note that everybody wouldn't present like the ones that I've just shown you. Elderly people and immunosuppressed people have shown in this outbreak to present in atypical ways as well, which can be more difficult to consider. Okay, in terms of management, It's a droplet spread condition, exactly like influenza, and this is information mostly gained through the SARS outbreak. So it's an assumption that the coronavirus transmits more or less the same as SARS, which is the same as influenza. I just want to quickly explain to you what droplet spread means. You get two different ways of respiratory transmission of diseases, droplet spread and airborne spread. Droplet spread can sometimes be aerolized, meaning that it can break up into smaller particles that can float in the air, and that is usually in the hospital setting. There's certain procedures we do, and then the droplet spread changes to airborne spread. Droplet spread conditions you can see there, and included at the bottom is your coronavirus. Airborne spread is the ones that we know very well as tuberculosis, measles, and chickenpox. Okay, so to get back to the infection prevention and control measures in the hospital setting, we would immediately isolate the patient in a single room and apply contact precautions. And I'll show you a little bit more about what we mean by contact precautions now. But the crux of contact precautions is hand hygiene. That's the most important thing. And we add a few other things to that. And then droplet precautions. And in the hospital setting, again, we would also cover for potential aerolization of those droplets. In other words, instead of just using ordinary mask in the hospital setting, which is adequate for droplet spread conditions, we would add an N95 mask, which is a little bit better, but we use for TB, and we also use eye protection. Because in the hospital setting, when you have to intubate a patient, etc., there may be secretions all over the place. With regards to personal protection in the hospital setting and elsewhere, we usually adhere to standard precautions. That should be the minimum infection prevention control that we do every day. Hand hygiene is already a major component of that, and then we often add extras like gloves if you have to take blood or do different procedures to the standard precautions. But then you also have something that we call transmission-based precautions. Those could be either contact precautions, and we include isolating a patient, wearing a waterproof apron, and wearing gloves. That is adequate for contact precautions. Droplet precautions includes on top of the ones that I've already mentioned, a surgical mask that also need to be worn. And then we have airborne precautions that we would do when a patient has tuberculosis and so on. And there we add the N95 mask and eye protection. So if you're out in the public, what do you do to prevent? First, don't get it. In other words, continuously practice hand hygiene. Avoid touching your face and nose if you haven't cleaned your hands properly. Avoid close contact with people who have cold and flu-like disease, especially if they've got fever as well, combined to that. And then secondly, don't spread it. In other words, if you have a cold or a flu with fever specifically, always practice cough etiquette. Into your hand, into your elbow, or into a tissue or whatever, and safely dispose of that. Stay at home, don't go to work if you are very ill with a fever, and try not to have too much close contact. And close contact we mean 2 meters contact for droplet spread conditions with too many other people. So avoid public places, etc. And seek early medical advice to decide what is going on. And I think those are very easy things to do, but that we probably don't do very well every day. And I'm just finishing with the medical treatment. We would manage a case like this exactly the same as we manage any other viral respiratory tract infection based on the severity of the condition. The one problem here is that we don't have a specific antiviral treatment available. For example, with influenza, we do have some treatments that we can give, but with this condition, there is no specific viral treatment. We would usually give oxygen if the patient is severely ill. We would give careful fluid resuscitation because these patients are prone to develop acute respiratory distress syndrome, and you can easily overload them with fluid. So it must be done carefully. Breathing support, if indicated, in other words, ventilation, can be done in an ICU setup. The WHO recommends that high flow nasal oxygen and non-invasive ventilation should not be the first option, and should be only used in selected cases as prescribed by a critical care specialist, because there hasn't been a very good outcome with patients with SARS coronavirus being on high flow nasal oxygen and non-invasive ventilation. We would always consider the other diagnoses that I've already mentioned. We would be aware that viral infections can easily have secondary bacterial infections, so antibiotics is important. And then also because they may be in an ICU setup, one needs to prevent hospital-acquired infections in these patients as well. And then obviously the discharge comes in. You will discharge your patient from hospital as soon as they are well enough to leave hospital and tell them to go home. And the question that I don't really have an answer for is how long should they be in the home after being discharged, in terms of how long do they still shed virus after having had an acute illness. And maybe we can discuss that. Wolfgang, you may have some information on that. I think it's a priority to develop a vaccine, because that is something that is usually has massive public health impact when it is an effective vaccine. Thank you.
Everyone. So I'll be speaking briefly about the diagnostic aspects of the 2019 novel coronavirus. So just to briefly let you know, the samples that we expect to receive should actually be collected from patients who meet the case definition. And it's very important that timely collection of these samples in the course of disease is undertaken from these suspected cases. And the reason for this is that we would like to have as high a yield of the viral nucleic acid as possible, so that we can ensure that we provide with a very reliable diagnosis. The sample types will largely be upper or lower respiratory tract samples, and this will be based largely on clinical findings that have been undertaken post-investigation by the clinicians. And it might be nasopharyngeal or oropharyngeal swabs, and if you do collect a nasopharyngeal or oropharyngeal swab, it needs to be pulled together and placed in viral transport medium. It could also be tracheal aspirates, sputum samples, as well as bronchoalveolar lavage samples. And if you do collect the last three kind of samples, then these need to be transported in leak-proof containers. The other sample type that will be collected would be a blood sample, either serum or plasma. And for children and adults, it needs to be at least 5 to 10 mils of serum in a specimen tube. And for infants, it's a minimum of 1 ml in a specimen tube. It is recommended that you collect acute samples, so at time 0 at the time of presentation, as well as convalescent samples 2 to 3 weeks later. Obviously, there might be further testing undertaken for exclusion of routinely seen bacterial, viral, and fungal pathogens that we routinely encounter. And also the consideration would have to be made about travel-acquired infections. So necessarily, sampling will be also guided by those conditions and findings. So as the NHLS, what are we able to offer you currently with regards to novel coronavirus 2019? Following the publication of the sequence for the 2019 novel coronavirus, labs were able to design their assays and thus allow the general public worldwide to be able to design appropriate diagnostic tests. The National Institute of Communicable Diseases, which is our reference laboratory in Johannesburg, also offers testing for this coronavirus. The approach currently is that there will be centralized molecular testing for the 2019 novel coronavirus for South Africa and other African countries. However, it's very important to note that the testing for 2019 novel coronavirus will be limited to cases that meet the case definition of a suspected case. Persons without any epidemiological links to China and who do not meet the criteria for testing will not be tested. And this is because of the cost, the capacity, and poor positive predictive value that we're more likely to get a negative sample a negative result if you're testing a patient that has a poor pretest probability of being infected with novel coronavirus. And the previous speakers have already spoken about currently circulating viral infections that might be of mine. Thank you.
Here, I'm sure it'll take a lot longer to have a vaccine that is usable, and yet, should it still be necessary at the time, but be very valuable to protect particularly those who belong to risk groups. And interestingly, in the aftermath of SARS, my laboratory was involved in a biotech company's efforts to develop human antibodies, monoclonal, artificially made human antibodies against SARS coronavirus. And they worked in cell culture, which was what we did. They also worked in animal experiments, and that was published. And their idea was, as a company, to sell a few liters of the stuff to some governments as a stockpile for, should it ever be needed again. But nobody seemed to be interested. And then, of course, if your research and development pipeline leads nowhere, there's no money to be made, they shelved that thing. Now I've seen it's a preprint, so it's subject to peer review and full publication. But Chinese group has actually used one of these antibodies and seems to have demonstrated that it would also work against the new coronavirus. Now just imagine if we had a few 100,000 doses of that stuff that could be used in, let's say, hospitals in Wuhan and in other places where we have healthcare workers looking after these patients. It could be used in close family and other contacts of such patients. Wouldn't it be nice? But then, of course, if you think in 4-year or 8-year or whatever election cycles, it's very unattractive. And I think politicians have had their fingers burned with their anti-influenza drug stockpiles. And they were heavily criticized for that. And it's easy to do afterwards. Afterwards, when everything is played out, what was right and what would have been a better way. But at the time, needing to make this decision, I think we need to give people a bit of a benefit of the doubt. You can only do what you can do, and you need to use all relevant information and try to apply it as best as you can. But you can't predict the future. That is the big problem. So for me also that is a bit of a sad lesson that there might have been a product which might be usable in the current outbreak. Treatment is supportive. There is work ongoing to see whether there are any substances that could be used against, specifically against this virus. But for most viral infections, we actually don't have any proper treatment. Fever screening is in place and has been implemented also at points of arrival here in South Africa. I'm told that direct flights from China would only land in Joburg and in Cape Town. In other places, people would be sort of changing planes, and flights. But of course, we know that maybe it depends on where they screen. We also know that these measures look good, people feel good, and you may have seen amongst the pictures some large-scale screening taking place. However, if you're traveling during the incubation period, it won't be picked up because you don't have a fever yet. Yet when you arrive 2 days later, your illness may develop and you may become infectious. Likewise, when you travel and you don't feel quite well, but you have to go on travels now, I would take a paracetamol. What happens? My fever comes down, I pass through the camera undetected. Afterwards, it bounces up again. So it's only as good as it gets, but there are quite good studies from the times of SARS that showed how many million people you need to screen in order to catch one who actually has it. So it looks good, it shows things are being done, but we must not overestimate its effectiveness actually. So some unofficial take-home messages, and a clear disclaimer, this is neither on behalf of the faculty nor the National Health Laboratory Service for whom I work, nor the provincial or national or any government. So I would say we don't have a need to panic. Panicking doesn't help in any case, but in this case we really don't have a need to panic. I think that the South African, and I've seen in the aftermath of the ministerial announcement, there were some very critical sort of, social media statements and stuff, so people taking it down. Of course, if the lights flicker, you think, oh gosh, another ESCOM story. But I have to say that as somebody who works closely with the NICD, I think these guys are good. I think they're doing a fine job. And I must say that also working with the Department of Health here in the province, I think our measures are probably as good as they get anywhere. And that of course means that it doesn't exclude cases arriving. And if that outbreak goes on, we will see cases sooner or later. So many countries are seeing it would be a surprise if patients did not come to South Africa. And I think we are quite well set up to actually detect them early and to deal with them appropriately. And if in doubt, Dr. Taljaard will help about that. We have to be strict. You can't go overboard and now, you know, do crazy things and demand testing on all sorts of patients who don't fit the criteria, because you would swamp the system and you would confuse matters. It will not help, as Dr. Nkosi showed. You know, it doesn't help just to throw out testing. You want to do it very specifically for cases that need it. But of course, like all human things, you know, it's never perfect. So, I mean, nobody can exclude that things won't slip through. You remember that nurse who was returning from one of the Ebola treatment units in West Africa to Scotland. She was from Scotland and she passed through Heathrow. They had a screening station there and she reported that she was not well and had a fever and blah, blah, blah. And they said, well, you carry on and fly to Scotland. Next day, she was diagnosed with Ebola fever, acquired from a patient, and she was flown back on a high isolation unit, aeroplane, and whatever, for treatment. She luckily survived a famous case. But it was a spectacular failure of screening. You know, I mean, how many people do you get a day? And then you miss that one. You know, who comes to you and says, well, listen, I've been treating Ebola patients, I don't feel well. So, I mean, things do go wrong. And, you know, I don't think anybody can claim that we get it right each and every time. This advice for, I mean, important as it is, of course, and vitally important in a setting where you're dealing with suspect or confirmed patients. You know, the general advice that's also found in the Department of Health guidelines about cough etiquette and hand washing, and so I fully approve. You know, I think this is good stuff, and we should be doing it anyway, all the time. Specifically for this thing, no, because we don't have it. You know, I mean, you know, don't think that, you know, by washing your hands frequently you won't get this. You won't get it in any case because it's not here. So, but you know, it's still a good thing to do that. And remember, there's you know, tens of thousands of people getting TB infection every year here and other things. So you know, it's certainly good to do that. But don't, you know, be led to believe that this is specifically against just for the new thing. And the same goes for animal contacts. I mean, it's lovely to read, stay away from the markets, and don't buy, purchase, slaughter, or torture to death your own animal that you want to eat. Yes, of course, good idea not to do that, but at this stage, we are past that phase. We are no longer talking of transmission from an animal reservoir. We now have the infection amongst humans, and this is what we need to stop. Now, the sermon. Influenza vaccination. So we are in summer now, so luckily we don't have a lot of respiratory infections going around like this. In May or June, we will be going into our own influenza season. And then we have the same problem that they are now facing in the Northern Hemisphere. We've got a lot of people with signs and symptoms that look like flu, that also look like 2019 novel coronavirus infection. You know, it's simply not distinguishable. So my advice would really be this year more than ever, please do get your annual flu shot. There's plenty of it to go around. It's not by far enough for all South Africans, but still many times over what actually the uptake is. It's so poor. Please go and get your flu shot. Firstly, it lowers your risk. It doesn't absolve it because it's not a perfect vaccine, but it lowers your risk of getting influenza and serious, severe influenza. So that is good, of course. But also, should we have, you know, I don't want to paint a bleak picture, but should there be some local exposure to this new coronavirus at some stage, or you know, some scare about it, it will help if you are not the one that presents with fever and a respiratory tract infection, which is actually influenza, but until such time that we find it is influenza, being swamped with specimens, 2 days later they lock you in an isolation ward because nobody can be sure. So, and this is actually advice that is being given in the Northern Hemisphere right now. So, you know, try and deal with the differential diagnosis to the very limited degree that we can. So, influenza vaccination is clearly a good idea. And if you don't need it against this, it'll be a useful thing to have in any case. So, I definitely have made myself a reminder this year. I will remember to get it in time myself. Thank you very much.
Thank you.
Okay, my name's Mwangi. I'm from the Cape Argus. That's an interesting story because a couple of days ago, a woman who lived in Wuhan, a South African woman, and got back here on the 18th, got in touch and said she was a little worried and, you know, should she get tested and so on. So I finally got her the number for Tygerberg, and I think she spoke to somebody called Charlene there, and she was told she's in the clear. Sorry, and she was told she's in the clear. So, but I'm just curious. They didn't test her, they didn't see her, but she'd been 14 days, I guess, without any symptoms. So, was that the right diagnosis?
Yes, I think that's clear. It was 14 days.
It was 13, 14 days.
Completely asymptomatic, healthy, no problem after 14 days.
That's correct, yeah.
So that means you don't have the disease.
Right, there's a hand up in front here, and then there's a mic.
Hi, I'm Tanya Farber. I'm the science reporter at the Sunday Times newspaper. This is a very broad question, I guess, and maybe possible to answer at this stage. But how different would an outbreak look in a country like South Africa that does have such a huge burden of tuberculosis, in terms of, working out the symptoms and then treating it, and complications with TB and novel coronavirus together? I'm just interested to know. I think South Africa, we're very specific with our burden of TB. So how would an outbreak look here compared to countries where there isn't such a high burden of tuberculosis?
I really don't know whether we can know how it will look, because it hasn't happened. But it's more or less what we see in the winter time as well. We see patients coming in with the flu, which is a respiratory disease, and then in between there's a lot of TB patients. TB usually presents differently than acute viral disease. It usually has a longer preamble to becoming ill. Patients have what we call constitutional symptoms, which is weight loss, night sweats, which is not classically present in the viral disease, but it can be for a few days, but usually not for a week or two or even longer. So there are certain clinical features that you can use to try and describe. And then for TB, we have tests that we can do to get a same-day result on tuberculosis. The X-rays results also looks differently, so the clinical pictures are different. And that usually helps us to try and distinguish those. But I would say, as I said, it's the same as flu. If it occurs together, we would have the same problem as we've had with that in the winter months as well.
Here we go. Thank you.
Good afternoon, Vanessa Puna from the SABC. So as a designated facility here in the Western Cape to deal with the coronavirus should it present itself here, does this mean that patients that get seen in, for example, the private sector or public clinics, etc., will they immediately be referred to Tygerberg Hospital, or what will happen from the first point of healthcare to how do they end up at this facility, or what would the process be? Thank you.
Okay, so no, they will not, definitely not all end up here. We are the designated facility for patients that need to be isolated specifically for specific reasons and specific type of isolation, because we've got high level isolation available. But in general, all facilities, and that is the provincial approach as well, should be ready to manage cases and to identify cases, and then they would phone us and we would give advice in terms of the likelihood. And if patients are not that ill, they should actually go home and be home quarantined. And the WHO has got a very nice guideline on home quarantine and what to do and how to do it and what kind of advice to give. Only the patients that are very ill, that needs to be admitted, may be ventilated and need specialist care, would come to Tygerberg Hospital. We've had one or two potential cases at private facilities which turned out to be something else. Most of them do not necessarily want to send out patients to us. They would take care of them. They also have single rooms where they can actually manage the patients. So it will be exceptional cases that comes to us. But I think in terms of a countrywide approach, it's probably good to have certain centres identified and that can give advice. In our province, Groote Hospital and the Infectious Diseases Department are also very happy to take cases and be discussed with. So between Groote and us, and also Red Cross for the children, there would be adequate cover to help out.
I'm Malal Beninaber from Netwerk 24 and die Burger. I just wanted to get an idea here, Tygerberg specifically, how many beds do you have to deal with, this, if you have a special unit in the hospital dealing with these cases? Can you give an idea of the type of capacity you have? And just, is it a center that is usually used, or is it kind of boarded up until there's a next viral infection? Do you use these isolation areas often?
So we are the designated viral hemorrhagic fever referral site, and some of our isolation, not all of them, are in the viral hemorrhagic fever isolation unit, which is only used when we have an Ebola virus or something, or Congo fever. Those are only 4 beds. But then we have isolation facilities for our MDR TB cases and ordinary TB cases, which are much more transmissible via air, which have negative pressure in them. We've got 4 dedicated ones of ensuite bathrooms for the MDR, but for the ordinary TB, we put them on single rooms where there's extractor fans and take air out. And I can't even know how many of them there are, but there's quite a lot of them. But in a huge outbreak, there's no hospital in the world, not even in Wuhan in China, that would manage everything. So hopefully we won't end up there because then it will be an emergency. But at the moment, I think between us and Grooteskier and Red Cross, there's adequate isolation facilities for the odd cases that may come into the country.
Any more questions from the floor, from our colleagues? Yes, Amy.
Jantjie, would you advise adults older than 65 to also get the polysaccharide pneumococcal vaccine this year?
Thanks, Angela. Yeah, I was thinking about it when Wolfgang mentioned the influenza, definitely. The pneumococcal vaccine, very important, especially for anybody that's got a chronic disease, that's older, 65, even maybe younger, more than 60, and have any other immunosuppressive condition or taking steroids for something. The pneumococcal vaccine very, very effective in preventing pneumococcal pneumonia, which is the main cause of bacterial pneumonia, which I showed as one of our differentials. So I would definitely advise that. The small babies still usually get it as part of the extended program of immunization, but for adults it's definitely also indicated.
Also a staff member. I just want to know how long testing takes. So from the time that someone's suspected to you can either confirm or deny.
So what we're trying to do or have in place is that we would love to be able to offer you a result within a very clinically relevant turnaround time. And what we're hoping that will be is that from the time that the sample leaves or is received within the lab to about a reasonable turnaround time, so not more than 24 hours.
If I may add to that, so for the time being, the test is at NICD. So there's still a shipment that needs to be added to that, and for good reasons, because it's a new test, and there's various labs in the world that are evaluating different types of primers and so on. So it's early days, and I think it's perfect that there should be sort of centralized labs in different countries that are going through these early phases and making sure it all works. But the plan is that if this should get worse, and if there is sort of a daily need for testing in maybe dozens of cases, and remember, not all of them would be that new infection. It could, many of them wouldn't have it, but they still needed to be excluded. Then other NHLS labs, including ours, would also get these assays and would be running them. But I think it's a good solution to not rush for it now, because it's all a home brew at this stage. There is no kits yet. We struggle with controls because obviously the virus is not there, so one would have to make controls. So it's good to have it centralized, even at the expense of taking a bit longer than it would if you could do it in the periphery.
Hi, good day. I'm also a medical officer working in pediatric infectious diseases. I just wanted to make sure, I know we were talking about symptoms in the case definitions, and you briefly mentioned that atypical presentations in immune-compromised individuals. I just wanted to get an idea if we know what the atypical symptoms are. Are those sort of the symptoms like the runny nose and those that weren't that present? Or is it more that we must always have a higher index of suspicion in these cases?
She's working with pediatric infectious diseases. She actually gave us the answer. Yes, I think that would be it. It would be the less, maybe less kind of inflammatory kind of response, meaning milder symptoms maybe sometimes, or they may just present with, very ill, even without a fever, but just very ill. Yeah, so I think more.
Colleagues, we do still have some time. If you do have questions, just put up your hand high so that we can see. Yes, there's a hand over there. Oh, there's a hand in front here. While we get the mic to you, we're going to take the question in front here. Thank you.
I just want to know, let's go, colleague, in the case, if we identify any cases in South Africa, what would happen after this case is identified? Would there be follow-up with the people that this person has been in contact with? Or will we sort of just deal with this at hospital? Or what happens in the community where a person was?
That's a very good question, thank you, because I just quickly alluded to the public health response. But what happens whenever we get a case, while it is still a suspected case, a contact list is already being drawn up. So if you have a case that comes in with a flu-like disease from wherever, immediately part of the process would be our infection prevention and control nurses would ask, would go in after we did a medical assessment and start making, where did you sleep last night, what did you do there, who's the people that you had close contact with, and before that, until they can get to the point where the symptoms started. And try to get as many as possible contact people. If it was in a hotel that they stayed, they'll phone the hotel and just kind of say there's no panic, but we just want to say that we are making a contact list, and we will let you know about the results. So there would be a contact list, definitely. And when we do get the results, if it's negative, all of those people would also be informed that the test was negative. And if it's positive, obviously then we will have to inform them, okay, fine, are you symptomatic? If you're symptomatic, come in for testing, and if you're not symptomatic, be aware that you were in contact, and these are the things that you need to look at. Who are the staff? So at Atypical Hospital we have staff, and if you are on your own working as a single doctor, then it will be you. And the people that you ask to help you. That's how life is.
Hi, I'm a student here. We're seeing a lot of panic and spread of misinformation on social media. I wanted to know, what can we do as students and maybe staff to sort of control that situation?
Thank you. I think by asking the question, you've already done a lot, and you probably have some ideas. Social media is if you look at my blonde hair, it's not something that I'm involved in every day. But maybe you can use social media to fight social media, and maybe start a group against panic or whatever. So information, I think getting the right information out there. Students, Angela have done wonderful work on Stop TB. The same kind of approaches to getting the right information out there. And obviously then if there's really an outbreak, you guys would be the first ones we're going to ask to help us.
I was just wondering, with the Ebola outbreaks, they implemented a ring vaccination procedure. I was wondering, should a vaccination become available, would they implement the same procedure with people who had coronavirus or have coronavirus and have come into contact with other people? Would they implement the same ring formation strategy?
I suppose that depends on a number of factors. I mean, would one dose of vaccine help, or would it be 2 doses, maybe a period of weeks apart? Would post-exposure vaccination still give protection? I mean, there's many open questions that we don't know. Also remember that by that stage, we will be further in time. So, we don't know what the situation will be like then. So it's a difficult question. This is why I do believe that instant protection through antibodies, which is almost like your immunoglobulin administration, would actually be perfect in an outbreak like this, because you don't have time to prepare. You don't want to vaccinate all hospital staff for something which may never come during their working lifetime. So it's good to have something there and then give it to those people, which is simply not available. I don't know. I suppose it depends on a number of open questions. To be worthwhile in monetary terms, I mean, to make a good investment case for a company to produce this vaccine, I suppose they would rather use it broadly. I mean, to give it to many people, and if it can't be contained and it keeps circulating, this new virus, and we know these risk groups, maybe it goes the same way as the annual flu vaccination, that we want to protect healthcare workers clearly because they are usually exposed, and then those at risk because of underlying illness or age. Pure speculation at that stage.
Good afternoon. I'm Sister Lagrange from Victoria Hospital in Wynberg. I just want to make sure, if we have a suspected case, do we have to use the same protocol as in viral hemorrhagic fever and phone Tygerberg Hospital with the criteria and things, or do we keep the patient and, if necessary, transfer?
Hello, Sister. Yeah, you wouldn't necessarily phone Tygerberg Hospital. If you usually phone Groote Hospital, that's also fine. They would also be able to advise you on what to do. I think that the most important thing for you at the Victoria would be to at least put the patient in a separate room, put the contact precaution sign on and droplet precaution sign on in the front, and have all your PPE and things in place as you usually do, and then phone. And maybe a third sign that says don't panic. Yeah, but you can phone for the ski as well. It's not a viral hemorrhagic fever. It doesn't spread in the same way. It's a flu-like disease. It spreads like flu. So the advice could come from anywhere, and it depends on how sick the patient is whether you're going to transfer the patient or not. But that will be decided between you and the infectious diseases consultant on the other side.
Okay, I'm going to open the floor for the last time for questions.
Hello. I'm a student also working for healthcare workers. At what point do we consider protective equipment for all healthcare workers at some point? I don't know. I guess no suspected cases yet, but yeah, what's the number of suspected cases that we would?
Yeah, so we have got no cases, and at the moment also no suspected cases in this province, as far as I know. So as Prof Preiser said, it isn't here. So at the moment, universal precautions, which is hand hygiene and appropriate personal protection. So if you need to wear gloves for what you're doing, if you need to wear a mask if a patient is coughing, you should be doing it anyway, always. So if a patient has got respiratory symptoms because of the risk of TB. So you would use the universal precautions with appropriate other protection depending on the case. And that should be the rule every day.